Right. Good morning, Americas. Good afternoon, Europe, and good evening, Asia. We were very pleased to see you during our second Floaters Society webinar. And I guess when it comes to diagnosing floaters, lots of different approaches will be shown, and I'm very pleased and honored to introduce Dr. Paul Singh from US. Moderating the webinar with me. Good to see you, Paul.
Good to see you too.
And we're extremely happy to see Dr. Adamski from Poland as well with us. And obviously, he will discuss the ultrasound aspects of floater diagnostics. And I guess if possible, we'll try to answer to the questions which can be asked all the time. So we'll try to focus on them during presentations. We have 3 pre-recorded presentations, and in this case, we'll try to have the open discussion afterwards. I guess that's the easiest way we can get through it. But what I think is a great option in such case. We can try to interact with you and try to answer your questions when you actually see specific images. We can see that Dr. Tiezhu Lin joined us, and we're very, very pleased to see you here and looking forward to seeing your magnificent presentation. Good evening. How are you? Hope you can hear us. Okay, so let's move on through the introduction and introduction of specific methods. So for those of you who have seen our last webinar, many things will not be new in this aspect, but I guess it's quite reasonable to get through all diagnostic methods and explain the role in diagnosing floaters. So generally, we're going to cover the most useful tools in floater visualization. But what always comes to my mind is the question, which of those methods is really like the crucial to understand the role of specific floater in patient's eye? And I guess there's no clear answer to that question. And every one of us, depending on the method which we choose, like what we do together with Dr. Paul Singh and together with Dr. Adamski, we all use young laser vitreolysis to treat floaters, but for maybe vitrectomists, the focus in many cases will be slightly different, I guess. So obviously, traditional approach to floater patients is not the way we would like to treat those patients, because just looking at the Snellen visual acuity, which is in majority of cases 20/20, and clarity of optical media, makes it pretty hard to understand the real problem of the patient. But I guess the best method to show the real quality of life is what Paul is going to show. I mean, Aberrometry, which is a perfect and unbelievable tool, which gave us really pretty good overview of why patients are complaining that much of visual disturbances and poor visual quality. So what is a very good perception and the way we actually want to see the patient's way of perception is the clouds in the sky, because this is how the patients with floaters percept them. And when it comes to floaters which are extremely close to the macula, they are giving exact shape of the clouds within the macular region, and that's why so many of them with such a good vision are just not happy with what they see. But generally, even if majority of our patients are trying to explain us how it really works with the way they see floaters, in many cases, it's really hard for us to visualize them, because fundoscopy doesn't really tell us in many cases what's the location of floaters, especially in young patients. where we just see very, very transparent small floaters, which for many of them are really a big diagnostic problem, and the problem from the point of view of their perception. When it comes to their perception, many of us are focusing on patients' drawings. So from time to time, I'm asking patients still to do it, because it's not really clear in many of those eyes to say like which floaters are really the ones responsible for a specific problem. So sometimes understanding that the way the patients see is more important than just using specific ophthalmic diagnostic methods. But there's always a question if we can do more, and obviously we're trying to do more when it comes to ultrasounds and very different types of floaters and vitreous opacities or vitreous disorders. I guess it's still one of the basic tools and one of the first choice tools in the diagnostic process. And I think, and I guess Dr. Adamski would agree with me that especially when you start with YAG laser vitreolysis or similar methods which treat floaters, it is very important to understand the distances between the floater and the retina, but the floater and the back of the lens. So in many cases, measuring those distances, especially in the beginning of your floater journey, really makes sense. What is really important in those eyes is to have the standardized floater examination method, which basically starts with stabilizing the eye and trying to focus on the location of the floater in specific distance to the retina to assess the distances without any movement of the eye. Then you can go on more with a dynamic exam and see what happens during eye movements. But it's something what would be discussed by Dr. Adamski as well. And we're very happy to have extremely good diagnostic tools like the absolute ultrasound system, which when it comes to the contrast, which gave us a lot of space in terms of understanding the relationships between very, very small floaters and the rest of the vitreous. So the contrast, which is definitely much better, and assessing distances between specific structures really works well. And that's another approach with the iCubed, which is a machine I've been using for years, and especially in the beginning of my career with floaters, we have used iCubed machines to assess those distances. Something what I don't do right now in every patient I'm treating, but still I would definitely advise it in people who are starting their career in floater treatment. I guess wide field imaging and scanning laser ophthalmoscopy are two methods which help us a lot. And please treat this video as a tribute to Professor Tassignon, who is the president of the society, and her efforts to find reasonable diagnostic and treatment options for patients are always honored and appreciated by both our society and doctors around the world. And I guess it's very easy to see that the quality of SLO in assessing the movements of floaters is really crucial to understand their nature and the nature of patients' problems. When it comes to fundus photography, obviously traditional eye fundus photography makes sense, but I guess that presentation of Dr. Karl Brasse will explain us how important it is based on the picture and based on the ophthalmoscopic approach to assess the type of the floater, and based on the type, try to focus on the potential outcomes of treatment. So I'm still appreciating and honoring the way that Dr. Brasse taught us to differentiate floaters, still use it in my daily practice. And I think it's one of the best options to consider differences between different floater groups. Obviously, when it comes to understanding different floaters and shadows which appear on the retina. Fundus photography in specific approach, I mean, like focused on imaging specific depth of focus for floaters is the crucial aspect, and sometimes in many eyes it's not possible. So we're very happy to see Dr. Tiezhu Lin speaking about wide field imaging and wide field fundus photography, and so we'll be delighted to see Optos images to understand better the distances between specific floaters and how they can be seen after treatment. When it comes to the quality of life and quality of vision, I'm very privileged to see the presentation of Dr. Paul Singh, and I guess the introduction of eye trace has taught us a lot in terms of understanding quality of vision. So we're very happy to see the post-vitreolysis results, which were shown many times by Paul, and how magnificent outcomes in many patients are seen after these procedures, which actually changed a lot in our understanding of the procedure. And finally, when it comes to OCT, we're going to see Professor Adam Wylęgala's presentation, and he's going to focus on specific aspects of vitreous pathologies, vitreous shadows. But I think the most important aspect when it comes to the OCT is how important it is to visualize specific pathologies behind floaters, because in so many cases, like in this one, we are not able to see the retina properly, and the treatment process actually allows us to see the main concern of the patient. Diagnostic shadows are something what we see in floater patients on a regular basis, and in many cases, when their appearance is in front of the optic disc, so when we see that the floater is actually disabling the capability of the machine to measure retinal fiber layer or see the macular scans, then obviously floater treatment really makes sense in terms of assessing the retinal function much better. Obviously, there's a lot of more that OCT can do, and I always appreciate and like seeing the outcomes of sub-ILM hemorrhages and their treatment with YAG lasers, which is one of the most brilliant and spectacular applications of the YAG laser use, and how we see the rapid change, rapid improvement of visual acuity in those patients, and how easily we can assess what actually happens within that space with OCT. So definitely we need to find specific method which would be optimal for the patient with specific type of pathology. And it doesn't really mean that specific method is universal and should be used in every single case. Obviously, for floaters which are much closer to the macula, it's going to be very different than floaters which are behind the posterior lens capsule, and sometimes changing from posterior segment ultrasound to UBM really makes sense to understand the distances and potential outcomes of treatment. I'm very happy to see Paul talking about Aberrometry and his long-term experience with this method to assess quality of life. And I guess that in many patients you will see that actually a combination of those methods is the best idea to tell us the real outcomes. So we're going to start in a second with the ultrasound. Then we're going to have two pre-recorded presentations discussing the aspects of fundus photography, wide field imaging, and differentiating floaters. These two presentations will be followed by the presentation of Dr. Paul Singh, and finally pre-recorded presentation of Professor Adam Wylęgala. So thank you so much. I hope you had a chance to think about specific questions and maybe ask them during our presentation. So we're very open to see the questions. Please use the question and answer tab. I'm very pleased and honored to welcome Dr. Adamski, who is working with me and has been working with me for many, many years. So I think we'll be all honored to see his great experience with ultrasound. And let's just see what else can we do with this method.
Hello, everyone. Thank you for this great opportunity to join your team and to share our shared experiences with floater vitreolysis. And today I would like to talk a little bit about ultrasound, as you mentioned, in the process of preparing for this procedure or for the process of diagnosing patients with floaters. So this is me contemplating the use of ultrasound in our patient and contemplating whether it's going to be a good option for the patient. So let's talk a little bit about that. I hope you can see the movies well, because those online presentations sometimes cause some trouble with the movies. But back to our topic, back to ultrasound. Ultrasound seems to be a great tool in diagnosing the vitreous cavity, the vitreous body, because those structures and those tissues are composed mostly of water. So it's really a great environment for an ultrasound wave. So when doing ultrasound, when examining our patients, we very often, almost always see the vitreous body, right? Even if we're diagnosing some other problems, we often see the vitreous in this form or another. So, while doing ultrasound, we either directly or indirectly examine the vitreous by doing just our examination. But the question is, in our floater patients, in patients that complain about floaters, should we do ultrasound just in that group of patients? Should we do ultrasound in every patient that comes to us and complains about floaters? So the question is, why should we do ultrasound? Should we do it to broaden our diagnostic understanding of what's going on in the eye? Or should we do it for documentation purpose? So in order to confirm that the patient does have floaters, obviously, but also in order to document the progress that we may or may not have achieved during vitreolysis. So in other words, should we do ultrasound in order to show the patient, these were your floaters before we did the procedure, now your vitreous looks like that? So that is a question these are questions that I would like to to discuss during this presentation. Obviously, everyone that had held an ultrasound probe in hand knows that it is a dynamic examination. So it's not really objective in terms that we get a single frame of examination and that tells us everything about the situation in the eye. What I mean is that based on the position of the probe, we can achieve different images of the vitreous of the situation, anatomical situation in the eye. So in short terms, we can do this examination when we've got a large floater shown on screen, but also we can have some frames of the image without any floaters or without any significant floaters. So I hope you can see the movie playing more or less smoothly, but in case you don't really see it fluently. Here we've got an eye with a complete posterior vitreous detachment and with quite nice visualized vice ring in the middle. So that shows that only by doing a dynamic examination, only by moving the probe a little bit, we can visualize the situation in the eye, so we can see the whole floater. That's very important. So every time we do this examination, we have to take some time when doing that, and we have to choose those images correctly. So what I meant is that ultrasound might be tricky, right? Depending on the examiner, we may have the same patient with the same vitreous, with the same floater, and those examiners may present completely different results, right? So here we can see the same patient in the upper picture with posterior vitreous detachment and some minor floaters, but in the lower picture we can see the same patient, also posterior vitreous detachment, but quite a large vice ring in the middle here. What is also important is to remember that the vitreous is a very dynamic structure, so it moves along with the movement of the eye. So we have to really remember that, and we have to really ask our patients not to move their eyes a lot during this examination, because then we may not be able to capture the whole floater or the whole floater complex that's going on in the vitreous. So here in this movie that, again, I hope you can see playing smoothly, we can see a patient with, again, posterior vitreous detachment and quite a large floater in the central vitreous. This probe is not moving at this time, but the eye of the patient is moving, so we can see the floater appearing and disappearing depending on the situation. And as Dr. Dmitriew has said, we now have very modern, very high-resolution imaging systems using the ultrasound, which can really show us those floaters in good quality and very nice resolution. What is also important is, which Dr. Dmitriew also shortly mentioned, is the position of the patient that we're doing this examination in. That's especially important in those of us that start our adventure and our journey with laser vitreolysis, because in some of those cases we use ultrasound to determine if the floater is safe for vitreolysis. That's especially important when we don't really have this experience when looking inside of the eye during funduscopy in order to determine the safe distance. So always try to remember that we have to do it in the same position that we're going to do the vitreolysis in. Obviously, the systems that we have for vitreolysis right now are slit lamp based, so the patient is sitting up, and that's what we should do with the patient during ultrasound as well. We cannot really forget that, because our usual approach to ultrasound is the patient's laying down, we're using the probe and seeing what's going on there. So if we skip that part, thinking about this position of the patient, we may miss a lot of patients that could have benefited from vitreolysis but didn't, because we didn't do that examination. And that is one of my patients, my first patients, and I started doing ultrasound in a lying down position. I noticed that the floater is quite close to the retina, 1.5 millimeters. But if the patient sat up and I did the examination again, it turned out that the vitreous changed its position, and now the floaters was a lot more safe for this procedure. So for diagnostic process, in some cases, it helps a lot, especially in those early years of or months of the procedure or the learning curve. So in terms of the other question, in terms of question of documentation, what I mentioned in the beginning of my presentation about this subjectivity of this examination is what I want to get back to a little bit now. So in terms of documenting the process of treating the patient, so saving some images of a patient pre-treatment and post-treatment, I don't really think that's the best option because, as I mentioned, we can really do this examination in such a way that it either shows or it doesn't really show those floaters. So it might not be the best way to document and confirm the treatment. And I've got a patient here that I've done ultrasound, and I also done a color picture fundus photography. And we can see that pre-treatment, we can see the floater, and post-treatment, the picture with the fundus photograph shows the improvement a lot more. So in terms of just showing the patient, here it is you before, here it is you after, a color picture really tells a lot more than ultrasound, because an unsatisfied patient will look at that and tell us, okay, but these are the floaters that are still a problem for me, right? Even though there's no Weiss ring that's been present before, I can still see some floaters. I'm still not satisfied with what you did. And we cannot really tell the patient anything because he's right? There are some floaters seen in this ultrasound. So in terms of documentation, I don't think that's a good option for our practice. Some other uses for ultrasound in patients with floaters or floaters-related problems is asteroid hyalidosis. That's always a very impressive image, right? This storm of highly reflective particles in the vitreous, which are obviously a large problem for our patients. And what I noticed when having patients with asteroid hyalosis is that the image that we see, again, is not really the same image that we see in ultrasound. So what I mean that, again, this is the same patient with a color picture and a ultrasound picture. So it's a patient with very mild asteroid hyalosis. It's really just a couple of particles when doing funduscopy, but when doing ultrasound, there's a lot of floaters there. It's also important to say that the patient did not really suffer from any symptoms, right? The patient did not come with a floater problem. That was just an accidental finding that I've seen during this funduscopy. And I did ultrasound, noticing how many of those particles, highly echogenic particles, are there. So again, it shows us that ultrasound can show us a lot more floaters that are a problem for a patient. Sometimes when doing ultrasound, we have a problem with visualizing the vitreous. These are rare cases of a vitreous collapse when the posterior vitreous detachment is such extreme that it just gets the vitreous to the anterior part of the vitreous cavity. So this was a patient complaining a lot about symptoms associated with floaters. However, ultrasound showed me that, well, didn't really show me much. It showed me that the vitreous is collapsed, but I couldn't really say anything more about the quality of the vitreous because this area of ultrasound examination is full of artifacts and it's not very good for the diagnostic process. Obviously, some of our patients that will come saying, I have floaters, will have vitreous hemorrhage, which is blood being present in the vitreous body. Here we also have blood underneath the retina, so probably a vitreous hemorrhage associated with hemorrhagic age-related macular degeneration. Sometimes I get questions, can you determine if the opacities in the vitreous are associated with a hemorrhage or an inflammatory process just based on the ultrasound image? So it might be hard, but the image, the appearance of the retina and the choroid helps. So this is a patient with endophthalmitis, a lot of opacities in the vitreous, and also enlarged, widened retina and choroid. So that may help with diagnostic process. Hemorrhage located in this space between the retina and the vitreous body, and obviously ultrasound is a best way, or sometimes the only way, to diagnose that situation. And closing to the end, I'd like to stress out that not all floaters, not all opacities in the vitreous are associated with blood or inflammatory process. And sometimes what we see are patients with primary intraocular lymphomas. And I don't know if you can see, again, this movie playing smoothly, but this vitreous in primary intraocular lymphoma behaves very lazy. It's a very lazy vitreous, and it's quite constant in time. So if we get a patient with opacities that we suspect is a hemorrhage with an attached retina, we can observe the patient. But if the patient is not really changing and the vitreous hemorrhage is not evolving at all in a matter of months, we have to think about primary intraocular lymphoma in those cases. And really, as a dessert, I'd like to show a project that I'm quite proud of, that I did with Andrew and Dr. Dmitriew, about what happens in the vitreous during YAG vitreolysis. So what we did was Andrew was performing vitreolysis, and I was using a probe that I touched the eye and tried to see what's going on really in the vitreous. So why we did this project was, first of all, we really wanted to see if the thing that we're doing in the vitreous is not affecting the whole vitreous as it was advertised when vitreolysis was being introduced. So the point was to find out how much, let's say, damage, because that's not what is really happening, but how much turmoil is vitreolysis doing to the whole vitreous. And that was the first idea, to see that for ourselves. But obviously, we also wanted to show that to the other ophthalmologists, to the ophthalmic world, to prove that vitreolysis is really a local process, not really affecting the whole vitreous. Because when vitreolysis was being introduced, there was a lot of talk that it can damage the retina, it can cause macular holes, it can cause retinal tears, it can cause retinal detachment. So here we can see that it's a very, very, very local process, and it really only affects the floater that we're currently aiming at. So some take-home messages. We can obviously consider ultrasound as a tool in the diagnostic process, as well as a documentation tool for patients with floaters. However, we have to remember about some of the downsides. But together with OCT, together with fundus photography, it might be an effective solution. And as I especially like to stress out that ultrasound is a good way to visualize the whole vitreous and to visualize the aspects of floaters and the rest of the eye in terms of a 3D visualization for beginners. It helps a lot for the learning curve. Thank you.
Wow. Well done. Thank you so much for that fantastic presentation. Thank you also to Andy for your presentation, giving us a good understanding and overview of all the different potential opportunities to objectively identify and follow patients who have floaters, which we'll talk more about, of course, in the next speaker. But just want to, for a couple of questions I had for you. First of all, great images too. I love the quality of the images of the ultrasound. I have a question. I'd love to have anybody out there too. If you have any comments or questions, there's a Q&A box. We would love to interact with you all out there. So please feel free. And also, of course, Andy, Dr. Lin, if you have any questions or comments as well. But my comment and question, a lot of colleagues will ask me, Paul, for let's say asteroid hyalinosis, do you feel like there's even a role for asteroid hyalinosis in terms of YAG laser treatment? And do you feel with ultrasound, you have a better understanding of maybe which patients might potentially benefit? Because I found that it's hard just clinically looking at it with my slit lamp imaging to see kind of density as much as I want to, but then I use ultrasound. There are a few cases where I'm like, okay, it's consolidated, a little denser. I can maybe break up enough of that to minimize some of the obstruction. Do you feel that's a role for ultrasound for those asteroid hyalinosis patients specifically?
It may be because it really shows us the whole depth, right? Because if there are a lot of particles, obstructing each other, it might be hard to visualize the whole depth of what's going on in the vitreous. And we understand that asteroid hyalosis may be present also in vitreous that has not been detached, right? So, well, I think ultrasound helps a lot in order to tell if the vitreous is detached and where exactly those particles are located. That's a question that I've been wondering as well. Can we really help patients with asteroid hyalosis with YAG laser? I personally never tried that because I understand that that's a progressing disease. So even though I may help the patient for a couple of months, it might come back even worse. So I don't think that's the perfect patient for this procedure.
Well, great comments. I want to make sure we have some questions from the audience. I appreciate that as well. We have a couple. One from our good friend from the IOFS Society, Roxana. Is it possible to measure the speed of moving the vitreous, of the moving vitreous? Can you measure speed, and does that help you with treatments?
Well, I think you can measure the speed, but I don't know if it's going to be an objective measurement, and I don't know if it's going to help me with treatment. I don't really have an answer for that.
Yeah, to me, I mean, it's a great question, Roxana. To me, I think I look really at the behavior of the vitreous when I'm at the slit lamp with my 90 diopter lens, or just even without just looking at the slit lamp in the anterior vitreous. You can see how liquefied the vitreous is. And sometimes that can be a benefit because a lot of times these floaters maybe will sink to the bottom as you do a couple of shots. And you can have the eye move up and down. You can see the floater almost like causing this current. You can get that floater to come back to primary position. So sometimes when it's very liquefied, it actually can be a benefit depending on the patient as well. Any comments from Dr. Lin or Dr. Dmitriew?
Actually, I would have a comment regarding the speed, because we need to remember that during the ultrasound, there is more like a free movement of the eyeball, right? When we have the lens on the eye, and I'm very privileged to use your lens, Paul, for many years, and I really love it. It's a fantastic and the best lens which is used for vitriolysis. And then the movement is more like limited. So I don't really feel we can assess the potential speed of floater movement during vitriolysis in the same way as we can do it freely when the eyeball moves during the examination.
Yeah, it's very real time. I mean, with vitriolysis live, it's real time feedback, and you're just basically adjusting to what the floater is doing in real time, regardless. But it's a good question. I think I think the more we understand, the more we can help guide our surgeons as well. Another question I think that we'll probably answer at the end. A good friend of mine from here down in near Chicago area, who also is a very proficient vitriolysis surgeon as well, Christopher Wood, has a question about, or not a question, but a comment on really doing a MAC OCT before any type of treatment to look for VMT, et cetera, prior to LFT, just to see if there's any macular hole or any potential tugging on the on the retina. So it's a really good point. And we'll probably talk more about OCT towards the end when we have an OCT discussion, but it's a great comment, Chris. So thank you for that as well. We'll appreciate the comments and questions. Any other comments you had, Dr. Lin, before we're going to introduce you and your amazing talk? I know we have a talk on SLO and fundus photography, wide field, and I'm really looking forward to your talk as well, because I do find that it's great to objectively not only diagnose small retinal tears and detachments before any kind of procedure, but to identify floaters and to objectively kind of, I think, verify that we treated these floaters is really important. So I'd love to hear your thoughts, and looking forward to your presentation as well. So I think we have a pre-record.
Okay. That's an amazing presentation from Dr. Adamski, and that's very helpful for us. That's because during the vitreous floater treatment, we use ultrasound to check, not just for floaters, always for the retinal condition. That's because I also use the YAG laser for part of patients. So I would make sure that's safe. That's very important for doctors and the patients. So later I will present the, and we don't have all the scan laser or photomerscope. We just have the Optos. Later I will present my protocol and have done recently. And I would like to all the presenter give us some comments. Thank you. Okay, I will share my screen. Okay.
Excellent.
Okay. I think I did a record before, but today I think I would like to do the living presentation. Hello, everyone. I'm Dr. Tiezhu Lin from China. I work in Heai Special Hospital. I'm working on some protocol and treatment for floaters for several years. Today, I'm very happy to join this seminar. And my topic is the vision degrading myopia. We use the Opto to assess that. Vision degrading myopia is more popular recently, and most others in public papers to describe this the symptomatic vitreous floater recently.
Sorry, Dr. Lin, would you mind just sharing your screen for me, please?
I didn't.
No, it's not sharing at the moment.
Okay.
Yeah, I can see your screen now, and now.
Okay. I can continue.
Thank you very much.
Thank you. Optos is ultrasound, but not also wide field imaging system. It has become widely popular and routinely used in clinical practice. That could capture 200 degrees of retina, about 82% of retinal surface area in a single click. Right now, there are more than 1,000 Optos in China. I think that is several months presented on some news. Optos provides non-contact high-resolution images of retina quickly, even through a small pupil, using an ellipsoid mirror and vertical point technology. Optos is based on confocal scan laser, a photomerscope, and uses 633 nanometer red light and 532 nanometer green light laser for color images. We could notice the features of different vitreous retinal lesions on these Opto images, including the floaters here and the choroidal news, and also some aqueducts, and also hemorrhage, and pigmentosa, blah blah. The color of Optos is close to the real color, and that's better than the spectrum, the multicolor device. Today, I would like to talk and share about the effects of Optos on vitreous floaters assessment. That's program I have done recently. There are a few articles talking about Optos imaging for vitreous floaters. This paper is from the scientific reports. Singh used the optos ascending acute posterior vitreous detachment. In total, 196 patients, including 55 males and 141 females. The mean age is 58 years old. Visit a retina clinic mean 9 days after the experience of vitreous floaters. Papillary vitreous opacity was noticed on autopsy in 62.2% of eyes. We can see the color are marked. The purpose of our protocol is to investigate the sensitivity of optos imaging for observing vitreous floaters in vision degrading myopia. This is a cross-sectional study, a total of 420 eyes from 345 patients. All the patients presenting vitreous degrading myopia. All patients have the symptoms, and we assess that use the vitreous fundus examination, also combined with ultrasound scan. All the eyes were classified as having posterior vitreous detachment or not having PVD. The sensitivity of optos imaging for visuality of floaters was evaluated. We used the full pixels 39 0 multiply 3072 of optos images to find floaters. We also analyzed the associated factors with the visuality of vitreous floaters on optos images in the univariate and multivariate logistic regression analysis. All patients complained floaters symptoms and told before in either one eye or both eyes. The eyes with vitreous inflammation or hemorrhage were excluded. The eyes with poor quality images were also excluded. The visual acuity, intraocular pressure, refractive status of eyes was examined. We used the slit lamp with indirect lens to check the vitreous and fundus condition through a dilated pupil. The results would be combined with ultrasound scan to make sure vitreous floater exists. All the patients were performed optos imaging. We measured the shortest distance of floaters from the retina or ultrasound. Sometimes the highest reflectivity in the vitreous in that spot, just like here, we measured the distance to retina. Some vitreous have multiple, just like this. We measured both, and we get the average values. Two investigators would finish this work independently. The investigators would also find the floaters on optos images, and for the inconsistencies, the senior investigator made a final decision. This is a classic pair of photos. We could see viscerin here, and also the viscerin above the optic nerve. This is another pair of the floaters. That's the viscerin here, also here. We can see the vitreous detachment hyaloid membrane here. And also we can see this membrane here, just like opacity here. It's another pair of pictures. This is the line, it's the vitreous detachment membrane. Also, we can see a gray detachment on the optos. In total, 420 eyes of 345 vision degrading vision myopia patients were collected, and 340 eyes were PVD type. Another 80 eyes didn't have PVD. The mean age of our patient was 56 years old. 67% of patients were female. The vitreous floaters could be seen on ophthalmic images in only 47%, about 47% of eyes. That's sensitivity for all patients, and about 50% in eyes in PVD, and just 15% in eyes without PVD. That sensitivity is very low. In the univariate analysis, age and the distance of floaters from the retina and the floaters of PVD type were significantly positively correlated with the visibility of vitreous floaters on ophthalmic images. In the multivariate analysis, age and the distance of floaters from the retina were positively correlated with the visibility of vitreous floaters on ophthalmic images. The floaters in higher myopia eyes were easier to be seen on ophthalmos. PVD type floaters have a tendency to be evident on ophthalmos images. You can see not just about 0.1 the value. We could observe the sensitivity of ophthalmic imaging for vitreous floater in different age groups from this figure. The sensitivity becomes higher along with aging. Previous studies have demonstrated that as one ages, vitreous liquefaction worsens and the vitreous collagen changes. The loss of type 9 collagen causes more type 2 collagen fibers to assemble into a larger fiber polymers, which may increase the visibility of vitreous floaters on ophthalmic images. In contrast, as the population ages, PVD will account for a greater proportion. Larger floaters like a B-ring or a detached hyaloids are also simpler to find. On ophthalmic images, 25% of these eyes had shown other retinal problems, such as drusen. We have listed here, and epiretinal membrane, macular hole, peripheral retinal degeneration, choroidal foot spots, diabetic retinopathy, bone spicule-like pigmentation, or malignity nerve fibers. This is the classic picture of the peripheral degeneration. The epiretinal membrane here also is the news. It's the tears and also the foot spots, lattice we can see on ophthalmic imaging. So in brief, the sensitivity of ophthalmic imaging for vitreous floater is low, particularly in non-PVD eyes. Ophthalmics are used for adjunct because it can find many other retinal abnormalities that might be easily missed. Ophthalmic imaging floaters were more visible in older patients, eye with greater myopia and the floaters further from retina. So that's the basic results from our protocol. Thank you very much.
All right, thank you so much. Excellent study. We were always wondering how much specific distances from the retina and how much actual visualization protocols and visualization options can help us in understanding what is really down there regarding patient feelings, patient perception of floaters, and potential indications for treatment. And I think ultra-wide field imaging is absolutely crucial in this part. And we do exactly the same, and Dr. Adamski is using Zeiss Clarus to show us actual location of floaters in the way we saw in this presentation. But Dr. Tiezhu Lin showed us the correlation, which is really clinical. And I would just have two questions regarding your approach. Do you see clear advantages of Optos versus the old style fundus photography? Do you think Optos or Clarus, wide field imaging, can do much more in floater patients?
I think just the as my results, not less than half of patients we could find the floaters on Optos imaging, but that's very useful. That's because it's a 200 wide angle, and we can, sometimes we just use the indirect lens. We could miss some the degeneration in the peripheral retina, so that could help us to find more abnormalities and give good suggestion for patients. Also, if we would like to do some treatment, just like the YAG laser, sometimes we also use to evaluate the retina condition. That's very important for us. So I think even if the Optos is not does not have very high sensitivity for the floaters examination, but is also very useful for this kind of patient.
Yeah, it definitely is. And my feeling regarding regular, like the old style fundus photographies, is that we couldn't find those floaters in more than like 10 to 15% of patients. And sometimes we were just frustrated with the lack of visualization of those floaters. So I would have the second question, if you agree, because what comes to my mind is that possibly ultra wide field imaging, ultra wide field pictures, should be taken before every treatment session for medical legal issues. What do you think? Do you think it's the way we should go on just because of potential medical legal aspects?
That's a great question. I think the price, for the imaging is different in different country. In China, just about 100 RMB. Also, the patient would like they don't just listen the doctors tell what the degeneration or disease they have. They would like some data about color data. That's because they will go to see another doctors. That is useful data for them. So I think for doctors or patient, that's the necessary the examination. Yeah.
And we were getting convinced that ultra wide field in so many aspects of our life, not just floaters, is helping us a lot. Thank you again. Magnificent study, and thank you for letting us know that in so many patients with ultra wide field imaging, we can really visualize that. And it's my great pleasure to introduce the next presentation, introduce our great friends and fantastic speaker, Dr. Karl Brasse. Probably the person which I admire most for the quality of videos, imaging, and presentations to show us how differentiating different types of floaters, which help us in understanding the reasons why specific patients are definitely suffering more from floaters, and how to differentiate floaters to select different methods of treatment. Can we see the pre-recorded presentation, please?
Dear colleagues, I basically want to put the focus of my presentation onto the variability and differential diagnosis of vitreous floaters. I began offering laser vitreolysis to my patients in 2013. In Germany, I was the first being observed with spectacism by many of my colleagues. Therefore, I spent a lot of time and energy to produce media to teach and to share my knowledge. In particular, I have put my main focus on utmost security measures. Even the German Ophthalmic Society has meanwhile accepted laser vitreolysis and has adapted the official guidelines for the treatment of vitreous floaters. YAG laser vitreolysis is now accepted for certain well-defined cases. The treatment decision is based on taking a comprehensive patient history, thorough clinical examination, realistic expectations, and detailed patient information including the risks of the procedure. In comparison to other ophthalmic YAG laser applications, YAG laser vitreolysis differs predominantly by its specific technical equipment requirements. In addition, treatment is more complex and time-consuming. It requires appropriate experience and knowledge of the surgeon. It should be carried out with utmost care and accuracy. This is a case of a myopic patient suffering from a giant vice ring floater. It is a really ideal indication for YAG laser vitreolysis. Patients are almost always free of symptoms after the treatment. But unfortunately the success rate overall is by far not as good in other cases. Please note that not all vitreous floater patients are candidates for the laser treatment. I got the chance to publish an article including a summary of the principles of YAG laser vitreolysis and a new classification of vitreous floaters in January 2019 in the Journal of the German Ophthalmic Society. Luckily, the chairman of the Ophthalmic University departments of Göttingen, Bonn, Rostock and Kiel were co-authors. This was very helpful to give this new procedure some credit. Manifestation of vitreous opacities and possible subjective impairments are considerably variable. Therefore, not all vitreous opacities are suitable for laser treatment. A classification according to the histoanatomical origin of the vitreous floater material can aid the treatment decision and should be helpful for future research. All floaters which originate histoanatomically from the retina belong to the group 1. A classic example is an operculum from a round retinal hole. Patients are not often bothered by it. In case they do, treatment is possible. But as the operculum usually is far off the optical axis and access for the laser beam is technically difficult and might require contact lenses with prisms. This case shows the variability of vitreous floaters. We are looking at a giant floating cyst originating from the epithelium of the ciliary body, which histoanatomically is group 1. Puncturing the cyst with the YAG laser to make it hopefully shrink might be an option as an alternative avoiding vitrectomy. The peripheral visual field of this desperate 40-year-old lady with retinitis pigmentosa is already very much impaired. The floating cyst even blocks her central field intermittently. Here you get to see 3 different vice ring formations which have been torturing the patients. They belong to the group 2 and originate histoanatomically from the detached posterior vitreous membrane. The prognosis for laser treatment is excellent in this group. This is a vice ring formation surrounded by a dense fibrosis of the posterior vitreous membrane. This ocular pathology can be observed quite often in combination with a macular pucker. It requires multiple laser sessions and a lot of laser energy. I recommend to perform them over a period of a few weeks with a constant focus on ocular pressure rises. Still, remnants of the material will remain. You should consider to perform a vitrectomy primarily. This is a similar case, luckily less pronounced. The patient was quite young and decided to have a laser treatment done. But again, I recommend not to perform it in one session, and please be prepared that the patient might get high ocular pressure rises. Luckily, a good result without complications could be achieved, as you can see. When the patient presents for the first time, I usually perform a thorough clinical examination which includes movie clips of the floater. Here you see a spectacular movie of a floating vice ring. The diagnostic of floaters is by far not as easy as in these cases. It is very helpful and often essential to find the disturbing floater to make the patient look up and down, or to give the eye a gentle kick with the contact lens. This makes the floaters move and you might find the one and only that is the disturbing problem. Now we are going to talk about group 3 floaters. This group is unfortunately often very resistant to laser treatment. Those floaters are degenerative formations of the original framework of fine collagen fibrils. We find a huge variability of vitreous structures like cotton ball-like threads, clumps, clouds or bottlebrush formations. These are often just partially removable. Here you get to see a large floater cloud fixed on the optical axis. This type of group 3 floater is very much debilitating the patient. He does not just suffer from the floater but from a permanent visual impairment as well. Removing it gave the patient a high degree of satisfaction, but just for a few days. These 3 follow-up scans within a few weeks reveal the reformation of a large bottle brush floater in the periphery. YAG laser vitreolysis partially vaporized the floater material, but a huge part of it is just fragmented into numerous little pieces of collagen fibrils which unfortunately show the tendency to form new clumps like you have seen it in this case. To avoid this scenario of reforming clumps, I have successfully treated in this case just the little floater cloud and left the cobweb of floater strings. Every patient that presents to your floater clinic is different. Spend time for a thorough investigation and consider carefully which strategy for the treatment you want to follow. Please get acquainted with the basic physics of light and shadows. The wonderful textbook of John Karakoff is a treasure trove of information. The art of YAG laser floater treatment is not really just the shooting but to detect the floater which annoys the patients. Invest time to examine the patient thoroughly or you will fail. Here you can see the flight path in low altitude across the central retina with any eye movement. In motion rest of the eye, the floater always returns to this position. The diagnostic in this case was difficult and really time-consuming. The treatment was even more difficult, in particular as the clump was close to the retina and out of the optical axis. Luckily I was able to solve the case successfully. The desperate patient had several consultations before in different practices without a proper diagnosis. If you consider to offer vitreolysis treatments in your practice, you should know that this is not a quick and easy procedure to perform. Furthermore, you can easily traumatize the sensible ocular tissues. My speaking time in the course is restricted and I have to come to an end of Group 3 floaters. But please allow me one more spectacular case. This floater is almost a piece of art. It is not a joke, but its owner was a vitreous surgeon worried to have a vitrectomy done. Now I want to talk about Group 4 floaters. The floater material originates histoanatomically from the posterior lens capsule. On one hand they are almost always treatable, on the other they would not exist if YAG laser capsulotomies would be done with more care. Together with Dr. Tobias Neuhann from Munich, I have produced a teaching movie which we have posted at the website ifox.com. The movie shows step by step how to perform a perfect YAG capsulotomy, avoiding floaters or damages to the intraocular lens. We have even been granted the iFox Film Prize 2021 for this production. Finally, I will get to talk about the Group 5 in my floater classification. It is basically a dump for whatever vitreous opacity is left that does not fit into the histoanatomical classification. This is spectacular image of a sunken capsular tension ring. These days you see frequently silicon oil bubbles. Silicon oil is used as a lubricant for syringes used for intravitreal injections. These oil bubbles can be very annoying to patients. You cannot remove them by YAG laser treatment. If you do, you create a kind of snowflake-like particles from the burned silicon oil. Asteroid hyalosis can be seen very often. If patients are suffering from it, vitrectomy is the only treatment option. Let me finish my presentation, and in particular the Group 5, with a spectacular case which you might have never seen before. We are looking at the left eye of a 22-year-old patient. She came for a second opinion and was complaining of a massive impairment of visual acuity. That young lady had already an appointment for a vitrectomy. This slitlamp image reveals the diagnosis of an ocular amyloidosis. Systemic amyloidosis could luckily be excluded. The amyloid material is very much concentrated in the posterior vitreous membrane. This might have been the reason for the posterior vitreous detachment, which you normally do not see in a 22-year-old. Here you see that the posterior vitreous membrane has lost its transparency, which is the reason for the massive visual impairment. To classify this case precisely, we have a mixture of Group 2 because it is histoanatomically the posterior vitreous membrane and amyloid which belongs to Group 5. To be able to better understand this unique case, I have built a 3D model. The posterior vitreous membrane is detached but still sticks to the optic nerve head. The central retina in the Optos scan is hidden behind a curtain of amyloid. As said earlier, vitrectomy was already scheduled. The girl is just 22 years old. Aren't there alternatives, she asked me. My Dutch colleague Kees van der Wind has published a few cases where he has treated floater patients with gigantic vice rings with surrounding fibrous plates, which I have described earlier in my presentation. He did not vitreolyze the floater, but he did cut a hole into the posterior vitreous membrane to get the optical axis free. His technique is called laser T membranotomy. I was kind of nervous when I did apply his technique for the very first time, in particular in such a young patient. This Optos scan is proof the effectiveness of the laser T membranotomy. I have split up this complex procedure into several sessions on 4 consecutive days. In total 10,000 millijoules of energy were necessary to succeed. This is almost 50 times the amount you need to perform a regular YAG capsulotomy. That is kind of risky, people might say. But isn't a vitrectomy in such a young one not even more risky? Now I am relieved to be able to tell you that after a period of 6 years no complications at all did arise. The young lady just recently sent me a note telling me that she was able to finish her university degree and could get her driving license. What message could be more satisfying and rewarding? It shows that investing time, care and doing some literature research if necessary can do almost wonders using the YAG laser. Difficult cases I schedule out of regular hours to have peace of mind to achieve perfection.
That was I agree with you, Andy. His images and videos are just incredible. I'm in awe. So thank you, Dr. Brasse, for those incredible images. So I think my video is going in and out. 1 second here. Let's see if I can come back. There we go. I'm back. Incredible images. But I really owe a lot to Dr. Brasse too. I think all of us do, for forcing us to truly classify floaters, to objectify it. And this is a condition. This is a disease state. You know, we kind of minimize the impact of floaters and say, oh, just everything's a floater. But I think when you start to understand there's different pathologies, different etiologies of floaters, and some of them may have a better response to laser versus vitrectomy, I think it really forces us to really re-understand and refocus that. So, Andy, I'd love to ask you a question based upon Dr. Brasse's presentation. Do you find a certain type of floaters that you feel are just the go-to best response with YAG vitreolysis in terms of?
Yeah, we all know that vice rings are extremely well-directed treatment, but what we have actually learned from the classification of Dr. Brasse is that the remnants of the lens capsule should be treated exactly in the same way as any other material in the vitreous, right? And that's the real beauty of that classification, to let us know that we need to rethink our way of consideration regarding what can happen in the vitreous, and regarding treatment. That it's actually not just the vitreous material. It's any material which is obstructing patient's vision. And at the same time, I guess when you look at the clouds, which are in the center of the visual field, especially in the mid-vitreous, we know how hard it is to treat them. So actually categorizing those floaters let us explain the patients the specific types of floaters react better and specific just react worse. And sometimes when it comes to like inflammatory types, it's absolutely forbidden to treat when the inflammation is active, right? So different ways of understanding the classification, and I guess you have similar feelings. However, many of us have different approaches to YAG vitreolysis in such case, right?
Yeah, and I totally agree. I think first of all, he's absolutely right. Those class 3 floaters that are more amorphous in nature, that more diffuse, tend to not respond as well to the YAG vitreolysis. But I want to make a caveat to that. The more consolidated the floater is, even if it's a class 3 amorphous cloud, the better results we tend to find, the less number of sessions. But it does oftentimes require a number of sessions, because one of the risk factors that Dr. Brasse mentioned many times in his video was the risk of pressure spikes. And that can happen, not very commonly, but it can happen, especially in those post-YAG capsulotomy patients. If the floater is more anterior let's say a cloud-like structure. We think the particles might be migrating into the anterior chamber and causing a blockage on a TM and causing a pressure spike. I've had a few of those in my career. So I think separating the sessions over time is very, very, I think, valuable. And then also managing expectations. You know, patients sometimes don't understand why we can't do everything at one time. So I tell every patient, look, you have a large floater. One of the safety measures of a laser is that it doesn't blow up the eye. It's a very microscopic area of vaporization. But we can't do all the sessions or all the shots at one time. We'll separate it for safety. But if after one session you have some improvement, we'll do a second, we'll do a third if we have to. And then managing the expectations for yourself and the patient really does help a great deal. Versus a Weiss ring, you know, the class 2 from a PVD tends to be more fibrotic, tends to really absorb the energy laser very well. And it's easy to correlate patients' signs and symptoms. When someone has a Weiss ring, they really can clearly define it comes from here temporally, it comes in the middle, and they can see exactly the shape. And when they can describe it, you can see it. And so it's a very clear delineation. And those patients tend, in our publications that we present at ASCRS and AAO, only need to average of 1.2 sessions for a Weiss ring. So really with one session, for the most part, you're gonna get significant resolution. Do you find that too, that with less number of sessions needed for a Weiss ring versus a cloud-like third?
Exactly. When it comes to clouds, it's usually, I'm telling patients, look, we're going to schedule a minimum of 3 sessions, but it's always you who evaluates the outcome. And then you decide whether you still want to go on and see us to have further sessions. But what I'm really curious is I mean, like when it comes to the clinical outcomes of treatments, I'll be very curious to see your feelings regarding the classification versus the quality of vision outcomes, because it's not just the way we treat patients; it's the way they see, actually, right? So do you have any specific feelings, or do you feel that floater classification really correlates with the outcomes based on the Aberrometry?
I do, and we'll talk about that. You know, and my talk next is going to be on Aberrometry, and specifically we'll focus on those class 3 floaters, actually, the ones that are those amorphous clouds in the middle of vitreous. Because, you know, when we look at a Weiss ring specifically, we can't look at even, you know, visual acuity in a Snellen chart, because the obstruction or the difficulty in their quality of life is more of a distraction. You know, patients say, doc, I can't focus, I can't read because this thing comes my way. I can still see, but yet is this particle, this clump gets in my way and distracts me. But we're also finding with these amorphous clouds, class 3 clouds, depending on the density, they still may be 20/20 on the chart, or you know, whatever the Europeans is, 6/6, whatever it is. But the bottom line is they can still see very well, but the overall quality of vision, their contrast, has gone down. And we used to see anecdotally a lot, right, Andy? You do a treatment session and these larger amorphous clouds, and they come back, no change in visual acuity, but they say, doc, I'm seeing so much better. And we couldn't quantify that until what I'll talk about next, Aberrometry. So I agree with you 100%. It does correlate to what Dr. Brasse's classification system also represents.
So Paul, we're looking forward to seeing your outcomes and how you'll use Aberrometry to evaluate it.
All right.
Please go on.
All right, thank you. Let me go ahead and get this out and share my screen. Hopefully everybody can see this here. So I'll start with my fun little video. I'm not as cool as Dr. Brasse, but here's my little intro video. Here we go. All right, that was my cool intro video. That's all I got. I'm not gonna, the rest are pretty straightforward. But you know, I think it is important to understand, you know, can floaters decrease the quality of vision? Not the quantity necessarily in terms of the patient's overall experience, you know? And I find that patients will say a lot of times after vitreolysis, yeah, you know, I can see clearer in general, even though the Snellen chart may not look significantly different overall as well. And so I think that was the disconnect, right? The disconnect was what we're experiencing as clinicians after treating these floaters, whether vitrectomy or vitreolysis, that we're seeing these patients come back saying, doc, I can actually see better, but no difference there. And I think it depends really on, as Dr. Brasse mentions, one of my pictures here of a class 3 floater, kind of amorphous clouds that are in the middle of the vitreous. I think that is really one of the common type of floaters that just causes this kind of overall contrast loss. And sometimes, depending on the density, not a significant change in visual acuity as well. The more centrally they're located over the visual axis, whether it's in the anterior vitreous or middle or even posterior vitreous, that'll change the kind of the density on a scotoma that it causes. But the more middle anterior they are, the more it just causes a generalized decrease in contrast sensitivity. MTF will show you as well. Higher order aberrations. You know, what is the trefoil and coma. We talk about HOA in terms of cataract surgery, but really we see this also now, and I'll show you in the patient who has vitreous floaters as well. So it depends on the location, the density, the size, where and how much effect it can have on quality of vision. Here's an example of a typical kind of floater in the middle of vitreous. Here I'm using my titratable illumination using a slit lamp in the oblique position here, showing that there's a floater. And you can see as I go coaxially here, I can see the floater's a little blurred. It's hard to see because there's so much kind of glare. So I'm just going to move this slit lamp here oblique about maybe 15 degrees to get rid of some of the anterior glare. But I can see I'm still far enough away from the retina. So this is really a middle of the vitreous opacity. There's a lens capsule. So now you see here, I'm pretty much the middle of vitreous, far away. And I think anytime you're doing vitreolysis, we keep talking about this with every one of our seminars, give yourself the time to know where you are. So you see, I'm going about 3 or 4 times, confirming I'm not near the lens capsule, I'm not near the retina's out of focus, I'm truly in the middle of the vitreous. And I can start firing the laser, etc. And it does, as Dr. Brasse mentioned, you can break them up. There is some vaporization occurring, but it doesn't necessarily mean that they're going to be vaporized all at one time. You may push these floaters on the periphery and they may say, Doc, I'm happy. But a month or 2 later, they come back and Doc, I have floaters again. That's because those pieces that you broke up, they start to consolidate back together again. And that's what Dr. Brasse was mentioning as well, which is why we need that second or third session or even beyond, depending as well. But I also think too, multifocal lenses. We have a case series we presented at AAO a few years ago on increasing reading by 2 lines after treating these amorphous clouds here. So we have floaters in the middle of the vitreous too, these amorphous clouds like this, these multifocal lenses. You have that clump, that again, group 3, as Dr. Brasse mentioned, these are the kind of floaters where you can see significant impact. And what we've found, not only in MTF curves, which I'll show you, but we've also found reading J2, J1 patients after treatment, before J5, and I have some really amazing testimonials from patients. But these patients, you don't have to completely remove all the floater, but if you can debulk it, if you can decrease the density of these opacities, you can do enough to help decrease the effect on their quality of vision. And again, this is another video. I know Dr. Adamski and Dr. Andy Dmitriew have done some fantastic work, as they showed you earlier, on making sure that we know exactly what's happened to the vitreous. And this is another one of my videos, very similar to what they've done here, showing that you see here very little movement of vitreous beyond this large opacity here. That's the white lines you see are just artifact from the sound of the clicking of the buttons. But there's very little movement of the posterior hyaloid or even a millimeter surrounding that opacity. So these middle opacities are really, I think, primed to at least help address some of the issues we face. But the problem is, what does the data show? There's a lot of skepticism around vitreolysis, even vitrectomy from floaters, because again, is a disconnect between what we think is impactful for patients and what the patients really believe, right? And so anytime you do not believe that something is significant enough in a patient's quality of life, you're not willing to take any risk. And that's whether it's dry eye, whether it's any other condition in the body. And this is why it's important for us to appreciate there is an impact of floaters on quality of life, and it's willing to take that risk if there is a risk because of the impact it has. Now, historically, this is a slide that Andy, you've shown many years as well. This is talking about why we've seen this disconnect of data. Well, if you look at the data here, Delaney and others have shown, hey, floater treatment doesn't really work as well. Well, if you're using lower energies, 1 or 2 millijoules, you're not going to sufficiently vaporize that floater. But another thing too is you look at other data sets when we're looking at acuity in 2 lines. The primary outcome analysis was, okay, success meant you need 2 lines or better improvement in acuity. Well, a lot of these patients I'm going to mention to you don't have improvement in acuity. It's improvement in their objective aberrations and the quality of vision as well. So that's why, for me, it was so important to talk about what I'm going to talk about now. That was a setup to this. This is one of the studies we presented to a few years ago, again, at ASCRS as well, and it's showing us how we can objectively determine the impact on quality of vision for these patients post-vitreolysis. And specifically, I'm going to talk about those amorphous clouds in the middle of vitreous. And Andy showed this slide earlier in his overview presentation. This is called the eye trace, which is ray tracing. It shines 256 lasers, basically, through the cornea, through the lens, through the vitreous to the retina. And it actually looks at point spread function, looks at where those lasers should fall in the retina, where do they end up falling, and the size and the shape of the actual image going to the retina. So it can, and because it has a built-in topographer, as you see here, let's see this topographer, it does wavefront Ks, it can separate cornea versus internal optics. So basically it can separate what are the aberrations of the cornea versus anything beyond the cornea, so which includes the lens and the vitreous. So if you have a cataract, it can do a great job of understanding, okay, what's the quality of it? It's called a DLI, dysfunctional lens index. Or if the lens is clear, or let's say hypothetically, what is happening beyond the lens, which is the vitreous. And we have to remember the vitreous is the largest structure in the eye system, in the visual pathway. And so let's show you and give you some orientation on what does this slide, what does this screen show us. The screen, this is the main screen I use. This is called a DLI screen. It's a very good patient-facing education tool. On the left here is the representative E, which is basically what the machine is saying, what is the quality of the image going through the eye, going through the cornea. So the bottom is the topography axial map here, and the top is what that shows the patient what they would see. Now, this middle here is something called the dysfunctional lens index. It's basically taking a lot of the MTF curves, higher order aberrations, all the behind the scenes, and giving you as a surgeon a basic understanding of what is the quality of image, and for the patient, are they seeing through the lens and beyond? So lens, vitreous to the retina. And it gives you a scale here. The scale basically, the lower that number, the less quality of vision you have. Think of it that way. The higher the number, better. Usually between 7 and above is considered pretty healthy. Between 4 and 6 or so, 4 and 7 is average, not that great. We're starting to get some decrease. Below 4 is considered very significant. That's kind of how I view it. On the right is kind of the total when you combine the cornea versus and the lens combination. Now on the bottom here in the middle is something called the opacity map. This means if any opacities in that whole pathway beyond the lens beyond, it'll show little clumps here of different colors that shows you how even the image is in terms of the quality of the image. And then also on the right here gives you a breakdown. Gives you a breakdown of the refraction. It gives you a breakdown of higher order aberrations, both total cornea, but also separates between cornea versus internal. And also because it looks at the visual axis, it can give you other parameters such as angle alpha, which is the center of the visual axis versus the center of the limbus. So for cataract surgery patients, it can be a very useful tool as well. But this is a patient here, it's going to show you, who is pre-vitreolysis for a large amorphous cloud, right? In the middle of vitreous, kind of similar to what I showed you earlier with those videos. And what you see here is in the middle, the DLI is 3.79. If you look on the bottom here, the corneal aberrations, 0.083. Anything less than 0.15 or 0.2 is considered insignificant. So not as significant, rather. So the cornea has very little aberrations to it. Internally, though, on the bottom here, 0.195. So significant aberrations of the internal optics, so lens to the retina, so vitreous included, right? So we did vitreolysis one session. We had the patient come back the next morning and check this out. Look at that. The DLI went all the way up to 10. You see here the image quality here, this E looks better. And you look here at the actual breakdown of the higher order aberrations. Significant difference. This is pre on the left here now and post. You see the total aberration went down, but the corneal aberration did not change, right? The cornea is exactly the same. Topography map looked the same. Aberrations of the cornea looked the same the next day. The only thing that changed was the internal optics. The refraction did not change significantly between day one. And so it's not a refractive error change, wasn't a bad scan. This is just truly, we got rid of the floater. Now, if you look here, that's pre and post. Now look here, even more details. Andy showed you this slide here. This is the MTF curves, modular transfer function. Now what MTF is looking at is contrast. How far do two objects have to be from each other for us to distinguish the two objects? That's the way to look at it. So at 10 cycles per degree here, you want to be about 0.6. That's kind of the quote unquote normal MTF that you expect from any healthy individual, right? So this is pre-op here on the left, showing us that this patient had a significantly decreased modular transfer function. Contrast. Now remember, this patient was 20/20 on the visual acuity charts, but look at the contrast there. See the average height here, and you see the refraction again. Now on the right here, looking at this, the refraction did not change, but look at the significant improvement post-vitreolysis on the MTF curve. You significantly increased, almost doubled the contrast sensitivity of this patient. And this is what the patient was telling me. Doc, you know what? I can't read as well. I feel like I need, even with more light, I have a hard time driving, not as clear. But the patient was 20/20. Did not have a significant glare testing that decreased her visual acuity. So this is why we're now seeing objectively that we can quantify the amount. I was going to show you a few more. That's a patient I've shown a lot. There's a couple other patients. I don't think Andy may have seen these too, but there's a number of patients. We have a library of patients who we've seen pre and post for these type of patients. On the left, this is another second patient here where you see the arrow on the left showing us the MTF. This is, again, internal So from the lens to the retina, you see how low that MTF curve is. At 10 cycles per degree, we're here about less than 20%. Here's the refraction in the middle here. This is again pre, and showing us again all the breakdown of the aberrations, coma, spherical, trefoil. Now on the right is the actual post-treatment, same patient. And you look at that, the refraction did not change significantly. You see here angle alpha means that the scan was perfectly centered. Same, everything's the same. The only difference is the MTF curve. And look at how significantly we increased the MTF, the modular transfer function contrast, and the HOA, the higher order aberrations, coma and trefoil, we could significantly. Here's another patient as well. Here's another case, case 3. Again, same idea. On the left is the MTF curve, not as bad as the other one here, but 40% versus should be about 60% there. So slightly decreased. You can see again, the breakdown of the higher order aberrations. There's refraction. And you see the same thing here. You significantly increase to normal from 40% to 60%. You now have increased the patient's modular transfer function. And the topography, no significant changes on astigmatism, refraction, etc. So these are some examples of what we can see. Now, this is another way in the same patient to look at it, looking at something called point spread function. So remember, we shine those lights through the cornea, through the lens, through the vitreous, and it looks at where does it fall on the retina and how consolidated are those points when it falls on the retina. On the left here, pre, you see here, you see the spread of those points here. Now, if you look on the right, that same area here, I'm just gonna show you here. There's pre, on the right is post. And if you see how more consolidated those lasers are as it hits the retina, that's the scatter from the floater. On the left beforehand, because the floater's in the middle of the vitreous, it was causing those rays of light to scatter. Right? And that's what caused the point spread function to be wider on the retina. But here, because you remove that opacity, you can see now, look, it's more consolidated as well. So this is really, I think, one of the reasons why we can now really believe strongly this is telling the truth. This is the control eye. This is the other eye. This is the right eye of that patient here. Just showing you, again, the contrast, same scans, was good. DLI was good, patient had no floaters. So again, this is showing you that it's not just the machine telling us something. The other eye was doing very well too, had no symptoms, had no floaters, and you can see how nicely healthy that other eye was as well. So these are kind of the examples that we're finding. And so in our breakdown in the study that we presented a few years back now, we looked at, in this study, we now have done hundreds and hundreds now, but in the study it was about 36 eyes, 33 out of 36 eyes had a significant improvement in the study of HOA and or DLI, right? The average improvement from a DLI number was about 3 points. So in other words, you went from someone who had mild, let's say decrease in quality to normal, right? That's about 3 points there. So you can really significantly improve someone. We had about 0.16 HOA improvement, higher order aberrations, and specifically, interestingly, it was trefoil, the different kind of aberrations. And we found trefoil significantly improved and was a high correlation to patients' symptomatic improvement as well. We were able to increase the height of the MTF curve, the average height you saw on that machine, by 0.217, which is pretty significant, about almost 50% improvement in the majority of patients as well. And we didn't see a significant difference in phakic versus pseudophakic patients. And so again, these are patients who had no cataracts or significantly had pretty normal looking lenses. So obviously if I have a cataract, that would muddy the waters. But phakic healthy eyes or pseudophakic eyes that were clear capsules, we did not see a significant difference in terms of the improvement as well. We did about 500 shots on average for each session. Average millijoules, I'm going down at about 5.5 on average, but I went to about 6 millijoules for some of these patients, a little stronger. But again, we had some patients who had an improvement in the Snellen acuity, but majority of patients did not have a significant difference on their Snellen visual acuity chart, in fact. And so again, that's the reason why this is so important. It's not only about the visual acuity as well. In the study, we had no adverse events, inflammation, IOP spikes, or retinal defects as well. And in our data in this study, about 92% patient satisfaction. Again, doesn't mean it's 100% resolution. And when we talk about patient satisfaction, it's important to recognize it's not about 100% improvement, but hey, Mrs. Smith, do you feel like this made a significant difference? And 92% of patients in the study said it made a difference as well. And so real quick, I know we're gonna talk about OCT next. I'm not gonna go into detail, but in these patients, this is one of the patients I had in the study, you can see here the OCT rendition. So showing the shadow, and as Andrew mentioned, as we'll see here with our next talk, Wylegala is going to talk about the fact that we can see shadows in the retina. Here's an amorphous cloud, middle of the vitreous, and you can see here shadow casting after the treatment and the patient number 2. You can see here the shadow's gone as well. So again, we're seeing correlation with OCT, with aberrometry and patient symptomology, all corresponding to an improvement as well. I'm just going to fast forward to this. This is just another video or another slide about OCT. We have a publication at OSLI talking about the fact that we can see significant improvement in these shadows. And this patient, by the way, had a scotoma. Patient came in with referrals from other doctors, having MRIs, FAs, and other diagnostics, and no one could diagnose why this patient had a significant scotoma. Well, there you go. You see that shadow in the retina? We treated the floater. You can see there's 2 pieces left, but we treated the large circle here, hemisphere there, and you see the shadow's gone as well. So again, these are all diagnostics that can help us, but specifically with the aberrometry, when you have those amorphous clouds, it can really help as well. So again, floater treatments it's such a wonderful tool to help our patients, and something we can't forget, especially even the pseudophakic patients as well. But thank you for the opportunity to be part of this. I appreciate that.
Thank you, Paul. It's really amazing because for so many years we've been trying to assess what is really changing in the quality of vision, and we're lacking the tool. And I think iTrace just perfectly filled that gap in diagnostic process. And I believe that you've been using it for how many years? Like 5 or 6, right?
Oh, yeah, more like 6. Yeah, 6 years, I believe, at least now. It's been a long time, thousands and thousands of patients, and it's a consistent. This is not just a one-off patient. I mean, if you have those amorphous clouds, and it's amazing how they don't have to be as dense as we thought too, and it can be not as large, but if it's enough in the visual axis to cause a scatter, it can definitely decrease the quality of image. Absolutely.
I was just wondering, because we see so many of those young patients where actually you can't really find any significant floaters in the vitreous. Sometimes you think it's completely clear. Do you find any abnormalities on iTrace in those patients? I mean, like, can you really assess the missing gap in the function?
You can. To be fair though, I've limited my use now of vitreolysis in the younger patients, not because I think it's unsafe or I'm worried about anything, but the impact is not as drastic unless you see some more consolidated floaters. If I have some of these patients do have a lot of thin squiggly lines that are hard to identify that don't respond to the laser, and you look at the DLI on the iTrace and it looks still like low, like 6 or 7, and you say, okay, there's some decrease there, not as the MTF curve may be slightly decreased, but I haven't treated a lot of those patients because I've treated them, and sometimes you may not have the significant impact as well. But yes, the sensitivity of the iTrace can actually identify those patients and identify a decreased MTF and quality of vision.
Just another question which comes to my mind as the lens surgeon. Sometimes you have so many patients with not very significant lens opacities. I mean, like very early cataracts, and you see that those patients have floaters as well. And then it's like a question coming to your mind, like whether it's really phaco which we should do first, and then go on with safer conditions for yak laser vitreolysis. But can the iTrace answer the question, which is more likely to be a problem for the patient, whether it's a floater or the lens itself?
Great question. It doesn't have the ability to separate lens versus vitreous, unfortunately. But here's what I would recommend. Here's what I've done. You're absolutely right. By the way, regardless of floaters, the iTrace can help you. There are patients who have a little bit of nuclear sclerosis, little cortical changes. There may be 20/20, but they're having complaints. And then you do the iTrace and the DLI is 5 or 4, and you say, wow, okay, maybe this is significant. So just from a cataract perspective, it can help a great deal. What I would recommend, so you can have a floater that is mobile. The way to differentiate for me is if I do 3 scans when the patient's sitting in the room. And let's say I do 1 scan, it shows the DLI is low, and you're like, okay, is this floater? Is this from a lens? Have the patient look down, up, lined up, and then rescan. And see, is there a significant difference? If you see significant fluctuation in the DLI or the MTF curves with multiple scans that day with having the patient move around, that's usually floaters, because the scan itself should not change as the patient looks around and then scan it a minute later. So that's the way I've identified it. It's not the best science, I agree, but that will give you some understanding that there's some fluctuation in their DLI, which indicates it's probably the vitreous more than the lens.
Excellent. And I really love it. This approach is really helping us in understanding, like, is it really the phaco which should go first? And I believe that's something we should try and go on. But I loved your OCT images as well, and we showed exactly the same showing that it's such a important process in terms of treating floaters when it comes to understanding the macular function, macular situation in patients with epiretinal membranes, with early drusen, with so many macular disorders which cannot be properly diagnosed without having laser vitreolysis in such case. And I believe that the presentation of Professor Adam Wylegala will show us the importance of shadows and at the same time importance of imaging. So can we ask for the presentation, please?
Hello and welcome. My name is Adam Wylegala. I am Polish. I work in Silesian Medical University, but also at the private practice, which is the Centrum Medyczne Wylegala. I'm also a vice president of the Polish Academy of Ophthalmology, and I would like to share my presentation on floaters in OCT. But before I do that, I would like to thank the organizers for inviting me to this symposium. Unfortunately, I couldn't be live because I will be at Ever conference at sunny Valencia in Spain. I will do my best to try to connect for your questions, but I'm not sure how the Wi-Fi and my schedule is going to be during the conference. So thank you for inviting me, and please listen to my recording. Why floaters and the OCT? Well, firstly, because we see floaters in the OCT in a form of artifact, right? So as a disturbance, a form of shadowing over the OCT. But this is not the end of the story. Well, thanks to the huge and great improvement in the OCT technology, right now we have a very high depth of imaging, and we can actually see the floaters inside the vitreous. Secondly, we can identify the vision-threatening consequences of the floaters, like the vitreomacular obstructions, like macular holes, like retinal detachment. So it's basically OCT is a gold standard for retina imaging. So should it also be a gold standard for the floater imaging? And I would like to answer this question. Can we see floaters in the OCT? Sure. If we have a good enough system, we can see floaters in the bursa premacularis, naturally here, floating. We can see them in the vitreous chamber. There is slight, very subtle epiretinal membrane, but also we can see the floaters here. Another example is the PVD, an incomplete PVD. It's naturally not the largest problem that the patient has, but this can also cause some form of visual disturbances. But look here, deeper inside the eye, we can see also some sort of floaters in the vitreous. This patient is slightly older than the previous one, so he has a complete PVD. The PVD over the fovea is slightly thinner than like closer to the disc, so I can imagine that the patient can have some different type of disturbances. But anyway, this is not also the most important disease that the patient has, because there is the retinal edema due to the retinal artery occlusion in the temporal segments of the eye. So far, we've just seen floaters, we've seen PVDs, whether incomplete or complete, but right now this is going to be more a cause of vision loss. So the incomplete PVD that's causing a tractional macular edema here, right? So we have the traction and they are tearing up the retina. The worst case scenario is when we have the tractional tearing of the macula, and then we have the full thickness macular hole with the operculum. The operculum can also be floating somewhere inside the vitreous chamber, and then we have naturally a very disturbing floater. This is before the pars plana vitrectomy, and this is the image after pars plana vitrectomy. Yet another image of the tractional macular edema. So we have the traction, we have the cyst, and underneath we have the double layer sign. So there's double layer sign, but also OCT angiography shows us the vascular network, which is consistent with the CNV. So far, I just showed you the images of the floaters, but right now we are going to focus slightly on the treatment. I do not perform the vitreolysis via capsulotomy, so I have no idea about this technique, but I found this paper by Dr. Singh, and in this paper he used OCT as kind of like a method to optimize the YAG laser vitreolysis. So here we see SLO image, and in the SLO we see a giant floater here hovering over the retina and causing this shadowing effect on the retina. After the treatment, the floater is gone, so we don't see anything compared to the pre-SLO image, and also the shadows are also gone, and the whole image is also brighter and more detailed. Okay, so I think that OCT, especially this ultra-wide field OCT like the Plex Elite or Canon S1, are going to revolutionize the visualization of the floaters, because look how deep we are, and this is basically a 15mm scan. So we see naturally the PVD, but we also see the heavy floaters inside the vitreous, and right now we can only do that image using the B scan, using the ultrasound, but in the future, with more people buying into those expensive SwapSource devices, I guess this is going to be the gold standard of the floater visualization. Another image, also here we can see how nicely the vitreous is depicted on the wide field SwapSource images. Yet another, here we also see a floater and the shadowing caused by the floater, because on the previous images you didn't really see the shadowing because the floaters were far up there, closer to the cornea than to the retina. But if the floater hovers over quite closely to the retina, it's going to cause the shadowing artifact. This is the SLO from Plex Elite. I recommend you to also use the SLO, not only the B scans but also SLO, because this is where you see the floaters in like real life on the outface. And this patient has uveitis, so you see plenty of large floaters that are disturbing the image of the retina. And this is how the B scan is going to look at that patient. So despite the 200 kHz system and very good penetration in terms of visual disturbances, the opacities, in the media opacities, you see that there is no retina here, right? The retina is being basically, all the light from the SwapSource is being absorbed by the floater, and you see no retina here. Despite the hardships, we were still able to capture the floater, and it's pretty easy if you just change the focus or the Seagate, depending on your settings, on the type of device you use. You can do it. So you can see the floater. It's pretty hyper reflective. It's pretty dense, and it's also pretty thick, because just remember, this is going to be more or less like 200 microns in thickness, or even more in some parts. So this is the floater. This is again the same floater, but a different size of the scan. Another great way to depict the floaters is to perform the three-dimensional analysis. So if we have a three-dimensional analysis, this is the OCT angiography from the Canon S1. We see the neovascularization on the disc, but this is not what bothers us during this lecture. So here is the floater in form of a shadow, right? So this is going to be just what you see on the OCT angiography. But if you move the scan like we are going to do, you are going to see it's subtle, right? But the floaters are visible, especially here, right? So these floaters, right? Yeah, floaters here. Very nice. And this is quite useful if you just not only want to see the floaters on the B scan, but also see the spatial dimensions of how thick they are, how wide they are, how high they are. So this is quite useful. So this is the last slide that I prepared for you, and these are the floaters from the Benson disease. I can imagine that Benson disease isn't the best candidate to perform the YAG lysis of the floaters, but still they disturb very much, especially the en-phase OCT, like here we have. So these are the floaters, right? These are the Bensons, and then you see that there is like this dark hole on the en-phase OCT, and the en-phase OCT is yet another application if you don't have the 3D option in like swept source OCT. You can always use the en-phase, and then based on the shadowing effect, you can imagine how the floater looks like. So thank you again. Thank you very much for your attention. I hope you've enjoyed, and you see right now that the OCT is very helpful in diagnosing and monitoring the floaters. Thank you.
Beautiful images again. I love all these presentations with these images. I'd love to kind of start us off. I know we have about 10 minutes left here. Are you currently using OCT now consistently to help either diagnose or confirm floaters pre and post treatments? Anybody want to comment on that?
Sometimes we see another issue in specific eyes, and that's the basic reason why we use OCTs. And sometimes we just confirm the presence of floats in the center just by observing the macula. But I was absolutely amazed by the quality of that 3D visualization, which was shown at the end of the presentation, the Canon images, and that's actually what we're dreaming of. We're actually dreaming of seeing that floater and shadow, which is related to the presence of the floater, just to understand that much better before the treatment. I guess it's a major and then huge step forward when it comes to the diagnostic process. Don't you think, Paul?
Absolutely. And I mean, there's a number of companies now working on new diagnostics to help couple it with the treatment itself. And I think that's the next level of treatment options. I think to allow ourselves to utilize the diagnostic tools, OCTs, et cetera, to target, to confirm depth and where we are in relation to the retina and lens, to kind of create more of a standardized process, and to help from a safety perspective those surgeons who maybe aren't as comfortable knowing exactly where we are in the retina real time. But I think as we start to get better OCTs, better imaging, that larger kind of depth, getting more space for us to see, I think we'll see a better application. I mean, right now you're absolutely right. I do OCTs in everybody, but it's not because, and I know Chris Wood mentioned this earlier, it's not just because of the floaters. It's more because I want to make sure there's no ERM or some pathology that I missed, that they couldn't come back and say it's your vitreolysis that caused it. So that's the main reason why I do it. But I think we'll probably see more use of it as we get better technology. Absolutely.
I guess Dr. Adamski has a lot of experience in the treatment of macular problems, and so how often is that really the problem in your practice when seeing patients with age-related macular degeneration, that the floater visualization, I mean like the macular visualization, is obstructed by the floater presence?
Actually, the macular visualization it's not really a problem that I've encountered, but as you mentioned in your initial presentation, I get a lot of patients that had glaucoma misdiagnosed because of some defect in the retinal nerve fiber layer. Not only the optic nerve may be obstructed, but also an area around the optic nerve. So the OCT signal did not really penetrate through completely, and showed a suspected defect. And based on that, and probably some elevated intraocular pressure, or even not, there was a glaucoma diagnosed. So I even presented a case of glaucoma treated by YAG vitreolysis only because of removal of the floater that obstructed the proper measurement of nerve fiber layer by the OCT device. So yeah, that happens obviously, and when examining and analyzing those examinations, we always have to remember that.
Really good point.
Yeah, exactly. I actually had another question, because during a couple of presentations we summarized that in so many cases we are doing YAG laser vitreolysis, and we just know the borders much better. So I believe that the vitrectomy indications need to be discussed as well, and that's another space which will be filled by the third webinar. But I was really curious, how is it going on in China and in Asia right now, with the focus on YAG laser vitreolysis? Both with Paul, we've been so many times to Asia to teach how vitreolysis works. But I believe right now there are so many specialists performing it. Dr. Tiezhu Lin for sure would advise us how many retinal specialists in China are doing vitrectomies because of floaters, floater only vitrectomy. Do you have that knowledge?
Yeah. I do YAG laser for floaters. I also I'm a retinal specialist. I also do vitrectomy for floater patient too. But usually that depends on the doctor and the patient together. That's because the vitrectomy, that's the cost fee is very high. Not a lot of patients would like to do that. So in China right now, most patients would like to accept the laser treatment. Yeah, not too many patients, the doctor, and also some doctors don't accept this idea. That's because they don't think the vitreous floaters would influence the patients a lot. Also, they could not accept the complications such as the glaucoma or cataract, blah blah. So that's not very popular. I think American doctors would like to do vitrectomy, but not in China. Yeah.
Yeah, I mean,
any comments on that regarding US?
Yeah, I mean, look, I think that's we're having a hard time right now. I still believe strongly, and I do a lot. I do about 20 a week. And but it's still right now, the FDA is still pushing back on it. So a lot of these companies who make these lasers that are allowing us to have better visualization, et cetera, are not allowed to promote it in the US because of that reason. So that also then changes the narrative and makes doctors here feel like, okay, something's wrong with this procedure. It's not safe, it doesn't work, because the FDA is not allowing these companies to promote it. So we need more objective data. We need more studies that come out. We need to get the FDA and other societies on board. And that's where IOFS comes in. We're trying to compile our data, really get the message out there and try to create the narrative. Like this, floaters are real. They do impact quality of life and quality of vision. And therefore, I think deserves a right to have some treatment. And if there are complications, like any procedure, we're willing to take those small risks because the benefits overall are so great. So that's a narrative we have to change. I agree.
Sure. So I believe it's a perfect moment to mention that the next webinar will be absolutely getting beyond whatever we have seen before. And it's the 2nd of December, and we're going to be live with wonderful speakers, retinal specialists, vitrectomy persons, vitrectomy surgeons, retinal surgeons. We're going to have new approaches like photoablation. We're going to see the indications for vitrectomy presented by Dr. Sebak from US. So we're looking forward to seeing that, and at the same time, seeing Japanese experiences with YAG laser vitreolysis based on the multi-center randomized trial. So I guess we all wait to see that, to see those outcomes. And Paul, thank you so much for co-hosting the seminar today. And I guess we all saw how different methods are used in different parts of the world. Any words from you guys to add before we end up?
Silence. I love it. It's so good. It was so good. Now, thank you, everybody. Thank you, of course, and all your work. And thank you for moderating as well. And be safe, everybody. Keep up the good work and keep in touch. Thank you so much.
See you on 2nd of December.
Thank you.
Bye-bye.
See you. Bye-bye.